Good morning. Today is April 28th, 2022. We have our morning in-service on sepsis in the perioperative area with Dr. Kat Krukowski. I didn't want to butcher that on video. So we're going to go ahead and get started. Okay, guys.
All right.
Take it away.
We've got 4 brave people here in person. Love it. So we'll just get started. We're talking about sepsis, and most of it, it's a tough topic to talk about because a lot of it is about definitions. I tried to make it a little bit more digestible for you guys and more relatable here in the PACU area. So we'll go through that. So to just go through a little bit of an outline, we'll talk about the background of sepsis, the different definitions that have evolved over time. We'll talk about the current guidelines, which is particularly from the Surviving Sepsis campaign. Talk about a lot of the challenges to diagnosis, especially in patients that are coming to you post-operatively. And then we'll go through a case. That is my dog too, in case you're wondering. So some background. So it's the leading cause of death in non-cardiac ICUs in the world. It accounts for over 300,000 deaths per year in the United States. And if these patients progress to septic shock, the mortality rate can exceed to 40%, which is pretty shocking numbers wise. And it is the most expensive condition that's treated and billed to Medicare every year. So looking at some of the trends here in the US, so this data, it was from over, I want to say 8 million hospitals stays each year, and it accounted for 1,000 of the hospitals over 44 states, representing 20% of the sample size here in the US. It's kind of old data. As you can see, it's from the years 2004 to 2009. But all to say, you can see that there's an annual increase, 13% by year. All to say, sepsis is still a leading cause of mortality, and it's still very prevalent here in the US hospital systems. So going into some of the pathophysiology of sepsis, so you have an invading microorganism or any type of damage to the host tissues, and it creates this uncontrolled pro-inflammatory system that is caused by the host immune system. I'm sure you guys heard the term cytokine storm. And what you have is usually when you have any type of direct insult, you have on the left side of the picture, you can see that you have these infected cells here, and you get direct recruitment to that site to kind of heal. But with sepsis, you have the systemic widespread leukocyte distribution, which you will see in presentation of patients. You have decreased systemic vascular resistance, so that's why they have hypotension, and then you have an increase in their cardiac output to compensate for that. Going kind of more like broadly into systemic responses with sepsis. So you can have complications like septic encephalopathy. This is a transient reversible brain dysfunction. It can be due to inflammatory or ischemic or neurotoxic processes, which can cause delirium, and it can increase your length of stay, ICU admissions, cost, and can cause some short-term cognitive dysfunction. From the lung standpoint, you can have atelectasis, infections, and ARDS. A lot of sepsis you see ARDS patients, and that's more prevalent to the ICU than here in PACU. Blood transfusions too, they can cause immunosuppression, and you can have TRALI or transfusion-related associated lung injury, and then you can have DIC as well. So this is, when you hear of a transfusion level for hemoglobin of less than 7, it's more so to avoid these immunosuppressive TRALIs conditions that we have to keep in the back of our mind. It can cause liver failure and renal failure. And most of this renal failure is due to the renal vascular vasoconstriction that you get from the vasopressors that we use to treat sepsis. And they had defined this acute renal failure as any increase in your creatinine from the baseline creatinine 3 times, or you have a creatinine greater than 4. or initiating renal replacement therapy. You can have hyperglycemia, which we also see postoperatively in surgical patients. And it can affect your adrenal glands, causing adrenal insufficiency, which also contributes to poor vascular tone that you also see in sepsis. So this is kind of the dry material that we have to go through, but you can't really talk about sepsis without talking about the definitions of sepsis and how to appropriately diagnose. So sepsis 1 and 2 really primarily use the Sears criteria, which you see in the top of the box. So this looks at temperature, if you're hypothermic, hyperthermic, if you have a heart rate greater than 90, if you have respiratory rates greater than 20, and then if you have either leukopenia or leukocytosis, so having a white blood cell count greater than 4,000 versus greater than 12,000. This Sears criteria is actually really no longer, it's not in the current guidelines, but just to show you, for the 1 and 2 definitions, they had used the Sears criteria with a suspected infection. And then severe sepsis, which again is no longer part of the definition, that was having the Sears criteria with end organ dysfunction. And then now we currently use the sepsis 3 definition, and this currently removes that Sears criteria, which I had already alluded to. It uses SOFA. I don't know, have any of you guys heard of that? So it's called a sequential organ failure assessment. I put this Q-SOFA on here because this is what will be pertaining to you, and I'll highlight again kind of multiple times in this presentation. But the SOFA is what is used in the ICUs, and it's it uses more like lab-based objective values, and you only need 2 of those to identify patients at high risk. And then they defined septic shock then as needing vasopressors to maintain MAPS greater than 65, or if you have a lactate greater than 2. So kind of highlighting those definitions just a little bit more. This is from the Surviving Sepsis campaign in their current definitions that uses that Sepsis 3 guideline. So again, you have a life-threatening organ dysfunction caused by a dysregulated host response to infection, which we already talked about in the pathophysiology. And you can have organ dysfunction that is identified as an acute change in that SOFA score. And I'll highlight that SOFA table so you know exactly what we're talking about in the next slide. So you need a score of greater than 2 points. And the reason why this is so important, because if you have any of those, that change or that delta change of 2 points, you have an overall mortality risk of 10%. Sorry, the patient is going to go to sick leave. Great. Okay, so here's the SOFA assessment score. So again, this is more for ICU, but just, it's hard to really talk about sepsis without knowing the full definition and how you really diagnose sepsis, other than you know, you see an infection and they have the clinical picture of it. But he says the objective data that they use in the ICUs. So what you do is you score it 24 hours after admission, and then you do it every 48 hours, and hence it's why it's called the sequential organ failure assessment. And you use these 3 different organ systems, and you give a point 0 to 4 with a, you know, the total score of being 0 to 24. If you have a higher number, you have a higher predictive mortality rate. So you can see here it uses respirations. It looks at the PaO2 to the FiO2 measurement. If you guys have ever dealt with someone with ARDS, we typically diagnose ARDS having a PaO2 to FiO2 ratio of less than 200. So they would have a 3 in this category here. If you have low platelets, that's going to add a higher score to your SOFA score as well, having a higher bilirubin with your liver function. And then if you're having, for cardiovascular system, they do it by MAP, and then it just gets an increasing score based on the amount of pressors and the amount of pressors that you're on. You look at a Glasgow Coma scale for the CNS system, and then creatinine and urine output. So these are all things that you guys do evaluate here in PACU. This kind of just lays it out in a objective manner. So again, just this is very repetitive, but septic shock then is, the definition is a change in SOFA greater than 2. You need to have vasopressors to maintain that MAP of greater than 65. And then you have an elevated lactate of greater than 2 despite adequate fluid resuscitation. And the reason why this septic shock definition is important to differentiate compared just to the sepsis 3 definition is because the mortality rate goes from 10% to 40%. And looking at this graph, I thought was very interesting just to highlight the SOFA scale. And we talked about that change in 2. So the higher mortality, the higher number in that SOFA score. And this shows you that as you have a higher SOFA score, the in-hospital mortality rate significantly increases, where, you know, anything around the 15 range has a 70% mortality. Okay, so if you take anything from this talk, it would be this slide right here. These are for patients outside of the ICU. So when you're coming to you and PACU, all their hemodynamics are going to be altered. But if you have any inclination that this patient just doesn't really look like, always keep in the mind, back in your mind, of sepsis. And there's been a lot of studies and data that showed this is the system that you should use to kind of have that light bulb go on, is the Q SOFA. And this is talking about tachypnea, so a respiratory rate greater than 22, any type of altered mentation, and systolic blood pressure less than 100. I'm sure you all are looking at this and say, all of my patients come to me like this, which is definitely one of the challenges that we see diagnosing sepsis early on postoperatively. So this is just kind of a diagram laying this out. Again, this is very repetitive, but you have someone that you suspect is an infection, a quick assessment of your Q SOFA with their respiratory status, their mental status, and then their blood pressure. And then you're going to say, okay, do they have any evidence of end organ dysfunction? This is where, you know, talk to us about, hey, maybe we should get some labs. I'm just a little bit concerned. We can evaluate for their creatinine. We can look at their liver function. If they have a Foley, look at their urine output. These are kind of just different things that you guys do on a daily basis that can kind of help guide you to that definition of sepsis. And then this is the further, just at that point, if you are really concerned for organ dysfunction, do a full SOFA scale. This would be the primary team as well. And then having the definition of sepsis when they need vasopressors to maintain that MAP greater than 65 and they have an elevated lactate level. Okay, surviving sepsis campaign. So previously they had recommended, this is like treatment for if you suspect, if you are diagnosing sepsis and suspecting it, what you should do. They had these bundles where they had a 3-hour bundle and a 6-hour bundle with different measurements to follow. But they found that really everything, the quicker the diagnosis of sepsis and the quicker management of it really does make an impact on patient outcomes. So they ended up now they just do this 1-hour bundle. That's because it decreased mortality from 37% to 30%. So we'll go through this in the next slide or the next couple slides in a little bit more details. But you're going to want to measure the lactate level. You want to give cultures before giving antibiotics. What type of antibiotics you want? Broad spectrum. You're going to give a bolus of fluids, and then you're going to start vasopressors. And again, this will be highlighted further on. Talking about a little bit of pathology with the source control, you have any type of microorganism that creates this toxic burden. So you have this inflammatory response, having a lot of cellular dysfunction and tissue injury that we kind of already alluded to. And the reason it's so important to find that source control is for appropriate antibiotic management, because they have found that any delay in antibiotic treatment will increase the mortality 7% per hour during that first 6 hours. So it's the reason why I kind of stress this point is because patients are coming to you. We contribute a lot of their hemodynamic status due to surgery and coming off of anesthesia and all of that. But really, if they have an infection, say they had a appy, and They're like, oh yeah, it was a little bit, purulent, but we got it out and it didn't burst, but there was some remaining in the belly. You guys could be really the first ones to kind of start that clock of diagnosing this and getting the appropriate antibiotics on board to prevent this increase in mortality risk. And it is shown that interventions, meaning drainage of those infected fluids or any debridement of soft tissue if you have a cellulitis picture, any of those interventions should be within 12 hours of diagnosis. You guys do this all the time. You look at the JP drains, you look at soft tissues. I think you guys do a great job at this, but always look if you're ever concerned. And then the diagnosis is also by blood cultures. And then you're gonna get imaging as well to confirm the site of infection. I thought this was an interesting table that showed the common sources of sepsis. So you have a patient that, and I'm just like spewing ideas, but coming in for a tonsillectomy. And so they're doing well from an airway perspective. They're not really bleeding through their mouth, but they're a little bit more tachycardic and they have a little bit of a low blood pressure. And you noted in the pre-op assessment that, they had this wound on their leg. And so just like think of the whole system where you're going to look at the leg. Maybe that's where they're having this septic infection, and that surgery was just the stimulus or the insult to cause this systemic inflammatory response. Again, this is just the Surviving Sepsis campaign of the importance of starting antibiotics within 1 hour for both sepsis and septic shock. You're going to want to do broad spectrum to cover all the pathogens. This is just a graph showing what I've already stated, but you can see that the black bars show the fraction of patients that are surviving to hospital discharge for effective therapy, given the time interval, and then the gray bars represent the fraction of patients that have received effective antimicrobials at any given point. So you can see that the fractions of patients that the survival right here goes down with the delay of antimicrobial start. This is more for people that are prescribing the antibiotics, but I think this just goes to show the importance of locating the source of the infection, because antibiotics are the primary treatment that will clear this infection. And we work here at Michigan Medicine where people have multiple comorbidities. They're allergic to 20 different things in their MyChart. They've been on antibiotics for multiple other reasons. So what will the source be? What antibiotics will essentially destroy the host? So those considerations is more for the primary team to think about, and that's why typically most patients just start on empiric antibiotics broadly initially, and then we'll de-escalate as we get those cultures back. So this is different measures that I don't know if any of you guys have ever seen this early goal-directed therapy if you've worked anywhere other than the PACU. But this was previously based off a study by this guy named Rivers. It has since been challenged due to it had failed to show that a mortality rate was decreased in like 3 very large randomized control trials. But it was just using more objective measures to guide your management and to guide the diagnosis of sepsis. But all to say, this diagram, I think you can still use these if patients do come to you with a central line or an arterial line, using these measures of having a CVP 8 to 12, a MAP greater than 65, and hemocrit greater than 60 to guide your management in these patients postoperatively. Another repetitive guidelines, but this is just kind of in bullet points here to refresh. You want to do early fluids to avoid tissue hypoperfusion. They stated that as 30 milliliters per milligrams within the first 3 hours. And we use balanced crystalloids over colloids just due to the risk of kidney events with a more concentrated solution like colloids. There is a point where we've given a patient 3 liters of crystalloids and they're still not maintaining their MAPs, where we can consider albumin so we don't cause pulmonary edema or bowel edema. So that will be of consideration, but is a very kind of low grade evidence for albumin versus crystalloids. You want to maintain your MAP greater than 65. The reason for this is they had looked at maintaining a MAP of 65 versus a MAP of 85. By increasing vasopressors or more fluids. And we found that the patients with a higher MAP actually had more arrhythmias. And the risk of having higher vasopressors was just worse compared to that MAP of greater than 65 group. You're going to do inotropes with norepinephrine as the first line. And then there's very low evidence for this sodium bicarb for pHs of less than 7.15. This is again just the Surviving Sepsis campaign kind of infographic about norepi as the first line. And then typically vasopressin would be the second line agent. Have you guys seen this? Like, have you guys seen the initiation of norepi here for a suspected sepsis and then addition to vasopressin if no one is responding?
Okay. A lot of times if the bubble isn't working, everybody like walks out the line.
Yeah.
So lining patients down here is less than ideal. Trying to get the unit before we do that.
Yeah.
But yeah, we've done that here.
Okay. Yeah, it's hard because I feel like a lot of this management you see more in the ICU. But it's still a good topic to know.
If there's no ICU bed, we're gonna be.
Yeah. Great. And then when the things that we just discussed, you're going to always reassess the patient. You're going to give additional fluids based on their status. We can, consider if things are just not going in the right direction, you're not convinced this is sepsis, or what type of shock they're in, because sepsis is a distributive shock. We could get an echo to evaluate their heart. And then you can, this was a low grade evidence too as well, but to guide your resuscitation efforts to follow those lactate levels. I will say sometimes the lactate can be a little bit skewed, especially if the patient's on a lot of vasopressors, because I know like epinephrine especially can increase your lactate. So you have these patients that have very, very low MAPs, you're on a lot of vasopressors to increase their MAP, and you're trying to guide your resuscitation efforts, but their lactate may be going up, not because they're hypoperfusing their tissues, but more so because they're on a lot of vasopressors. So something to keep in the back of your mind. Again, the challenges to diagnosis. So I really like this diagram. It shows how overlapped a lot of presentations and pathology can be with sepsis. So you can have an infection here on the left that doesn't really progress to sepsis. You can be bacteremic. That again doesn't progress to sepsis as well. You can have kind of these Sears criteria that again, we're not really using, but it's still good to keep in the back of your mind when you're evaluating patients. But a lot of patients like traumas or burns, pancreatitis can present in this fashion, as do hemorrhages, bleeding patients coming to you postoperatively, or any type of ischemia, or drugs, anesthetic agents can do this. So it can be very, very challenging to diagnose this here, especially here in the PACU. All right, let's talk about a case. So you have a patient that comes to you. This is your patient. They're tired, they're dead. And you're doing your initial assessment. You get handoff from your patient. He is a 64-year-old male. He has a history of hypertension. He has AFib. He's not on any anticoagulation because he had GI bleeding in the past. He has bladder cancer and he has kidney stones, presenting for a left ureteroscopy with laser. From the surgical standpoint, there was no complications. They had easy extraction of the stone and EBL was minimal. For the anesthetic, they did a general with an LMA. This patient got Tylenol preoperatively. They did 100 of fentanyl on induction. They didn't give any long-acting opioids. He got Decadron and Zofran for antiemetics, and total fluids were 600, and the urine output was lost to the field. So on arrival to PACU, you have a normal intensive patient with blood pressure 110/62. You have a heart rate at 96, SpO2 99, a temp 36.7, and a respiratory rate of 16. Looks like a pretty normal patient to you. As they progress in PACU, the patient begins shivering. So the patient was given 500 mics of fentanyl, or sorry, 550 mics of fentanyl. And then 20 minutes afterwards, they kind of have some soft pressures, 90/55, heart rate is 99. And so we just gave the rest of that LR bag, 400 to have 1 liter for the duration of this patient's course here. 30 minutes, the blood pressure still becomes soft and is trending downwards. So we gave 100 mics of phenylephrine with improvement. And then we recheck the blood pressure again after 10 minutes, and we have even a lower blood pressure. So we gave 300 mics of phenylephrine with minimal improvement, requiring norepi and vasopressin pushes. So what do you guys think of this? Is this something that would typically play out here? This was just like me coming up with a case. Yeah. So I thought this was very interesting, and this patient, and I was talking with one of my faculty members about this case, and it did present as urosepsis in a uro procedure. They got the stone out and they had some pyelo that just kind of disseminated, and it presented pretty quickly here in the PACU. But when you have a patient that comes to you and they're shivering, it's just anesthesia, like your whole thermoregulation is totally messed up. But really shivering could be the first sign of Rigers in sepsis, which is one of the first presentations of sepsis. So I found this in the nursing guidelines of the QSOFA. So just when you're always doing your assessment of patients, to think HAT, hypotension, altered mental status, and tachypnea. And again, going through this, I don't have a ton of great advice on how to differentiate. Just always, I guess, keep it in the back of your mind. So you have a patient that has a low blood pressure. They have many reasons for being hypovolemic. They have there are many reasons for having a low blood pressure. Is it a volume depletion issue? Did the surgeons not correctly estimate their EDL? And are they currently still bleeding? Did they have any bowel prep where they're just super, super dehydrated and hypovolemic? Could it be from a cardiac issue? If they have, all these scary things like having a heart attack or cardiomyopathy, any tamponade, these things that are always the ones that you want to rule out the scary things. Did they have anaphylactoid reaction? Usually if they had a full-on anaphylaxis episode, we typically present in the operating room within 30 minutes. But something to keep in your back of mind too. And then sepsis as well. Or is it just residual effects from anesthesia, especially volatile anesthetics, propofol, all the opioids, they all decrease your blood pressure. And then did they take their medications? Are they on several antihypertensives that they took today? So all of these reasons, think in the back of your mind. As far as that QSOFA too, altered mental status. So we have patients, they come to you here in PACU, you don't know what their baseline is, especially in an elderly patient, because having any post-cognitive defect in the PACU, if they have cognitive disabilities going or in pre-op too, that's like the #1 predictor of having any type of cognitive disability after surgery. Do they need their glasses or their hearing aids and their sensory impaired waking up? Are they having any type of emergence delirium? And a lot of delirium is actually hypoactive too, where they're not really with it. But the thrashing that you typically see, and you're like, oh, they're delirious, absolutely. But the more common form of delirium is actually that hypoactive, where they're just kind of like out of it and you don't really know. I've already mentioned how anesthetics can create that altered sense of mental status coming to you. And then are they in pain, or do they have any electrolyte abnormalities, or are they retaining CO2? And then are they tachypnic? So that respiratory rate greater than 22 in your SOFA score, are they still kind of emerging from anesthesia? Are they breathing really fast because they have a lot of pain? Are they anxious in a new environment, waking up and not sure who's surrounding them, in, just being in an unfamiliar environment? Are they acidotic? Do they have any lung pathologies that would make them tachypnic? And then surgical cause if they're doing any type of like thoracic case where they can't take those deep breaths and they're breathing at a faster rate because they have to take shallow breathing. And then so that's kind of in your QSOFA, that your differentials for all these different things. And I'm just painting the picture of why sepsis can be very, very challenging to diagnose. And I hope you guys can all appreciate that at this point. This fever one I thought was interesting. So the fever is, a temperature greater than 38.3, and how you can have variations in your core temperature on arrival to PACU. I see this all the time. You have a short case in a very frail patient, and you're like, oh, we don't need to put a bear hugger on because it's just a sedation case, and we're not even monitoring their temperature. But they can have a profound vasodilation effect, which would make them very cold very fast. So having an already lower temperature from the OR and then coming in, and if they had sepsis, that's going to skew because you're looking for fever, right? But that could skew your diagnosis as well. We already kind of talked about Rigers being one of the first symptoms as well. And then, for urology patients, you have them injecting normal saline into the bladder, which can make a patient very, very cold, which again, if they are presenting in sepsis, like in this case that I showed you, that could also skew because you're like, oh, but they're not febrile. So that's, I think, why they defined diagnosing sepsis as having that QSOFA with being febrile and not in that measure. This is just your differential for a fever. We don't really have to go through this. Another one is malignant hypothermia too, which can be a very similar presentation as sepsis. Another resource that I thought was helpful is just the indices of perfusion, which essentially states the same thing. Look at your map, look at your mentation, urine output, what can be tricky in patients who don't have a Foley. Feel their hands and feet. Are they cool? Are they cool? Do they have a capillary refill that's adequate? That's it. Stop sepsis. Save lives. That's all I got for you guys. Do you have any questions or comments about this? I'm sorry, it's not. It's very dry as defining sepsis, looking at all the objective measures. And it can be very challenging to diagnose here. And I don't really have great tips other than using those quantitative measures that are out there in the guidelines for a diagnosis of sepsis. But just knowing that not relating everything just to post-surgical, I think is the biggest takeaway, to always have it in the back of your mind for a diagnosis of you're just like, I just don't feel right about this patient. You always think, oh, they're just a little bit fluid down, or oh, they're still recovering from all the opioids I give them. Just think in the back of your mind to always have sepsis knocking on your door.
Thank you.
Yes, thanks guys. Yeah, it's my dog. Her name's Breck. Breck. Yeah, like Breckenridge. It is. It's a Bernedoodle. No, she's full. She's big. She's
Oh yeah,
she's big. Actually, the one up here she's like 85 pounds. I think.
Oh yeah.
Good girl.
She loves me outside.
Yes, it does. All right.
Okay, so you can stop recording.
Stop share. You can stop share and then stop.
Here you go.
Do it. That's fine. Let's see. That is still.